I am so excited and thrilled to have this opportunity to moderate this wrap-up session at this conference. I'm Dr. Entitlement. I'm a Associate Professor in Public Health at California State University East Bay. And for access purposes, I'm deaf, so I have a sign language interpreter. So any of the panelists, please feel free to stop me at any time and ask for clarification. If there's anything we missed, I can sign and the interpreter can speak to me. So I'm a white presenting woman with long brown hair, blue glasses, and red pinkish shirt with a white background. So today our wrap-up session focuses on missing links and connecting our learning to action. So the format of this session will be a moderated discussion. We're going to be thinking about each other's presentation, thinking about the aim of the conference as a whole, come up with some themes, coming up with a to-do list of takeaways. So I would like people to respond to each other, and in particular, I want Dr. Guerrero's to respond to what other people say from a policy perspective. Now, I'm going to do a brief introduction of our esteemed panelists. Dr. Guerrero is the chairman of National Council on Disability. Dr. Stephen Hinshaw, distinguished professor in psychology at UC Berkeley, professor of psychiatry and behavioral sciences at UC San Francisco. Dr. Clarissa Kripke, clinical professor in the Department of Family and Community Medicine at UCSF. Dr. Amy Hautwar is a professor of physical medicine and rehabilitation at the University of Pittsburgh School of Medicine. So today, to me, what is unique about the conference, we just focus on disability justice in medicine shared by Dr. Ryan this morning. I'm very curious about the thoughts based on my own experience. As a professor, I've experienced stigma and discrimination in healthcare setting, and I also do research in this area. Alice won today's set this morning from an activist perspective. The healthcare system needs full transformation. And I would like each panelist to respond for 5 minutes about what you think this transformation could or should look like.
I'm sorry, can you hold on for 1 second? Could we don't have anybody signing right now for Alina for the deaf participants in our audience. We need to get that straightened out. Do we have our second ASL interpreter? Sorry if this was any fault of ours, but is there any solution that we can think of?
From what I understand, the interpreter that we see on the screen should be able to interpret for the deaf people in the audience. We're back on track. Great.
Okay, thank you. Sorry to interrupt.
Thank you for checking in about that. I think we're back on track. So Alice Wong had this idea of full transformation of the healthcare system, and I wonder from you all what that might look like. I mean, today you might have been inspired to think about differently about what that might look like.
I can jump in with one of the things that Alice's talk brought up for me was the tension between services for people with disabilities being an entitlement, meaning that anyone who meets a definition of disability is entitled to services and supports, versus a need-based system. And Andreas, when you were talking about the medically underserved population designation, when that last came up for discussion, I was an alternate to that group. And what killed the effort to include people with disabilities was other underserved populations feeling that that they needed to, that it should be more need-based, and that there was a limited pie, and they didn't want to share those resources basically, and broaden the number of people who qualified. And when we're talking about systems that are entitlements, like Medicaid is need-based, whereas Medicare is entitlement-based, and entitlement-based things tend to be protected better. They tend to be funded better, just like Medicare is better funded than Medicaid. And in our Medicaid system, we're entitled to institutionalization. Nursing home care is covered, but home and community-based services are not part of the entitlement, and aren't necessarily covered. And so institutions are still funded better than community-based services. And our regional center system for people with developmental disabilities is entitlement based. There's a lot of disparities within that system, but I'm afraid that entitlement base is, as much as I think the self-determination program, where people can choose their own services and supports and don't have to use vendorized services that are vendorized by regional centers and approved by the government. While as much as I think I support that and want to use it, and think it offers people's choice and control, it also allows people who are wealthy to subsidize their services in a way that currently you can't do so well. Basically, whether you're rich or poor, if you have a developmental disability, you're going to need the services that are provided through that entitlement. And as soon as we allow people to sort of opt out of that and create their own private systems that are better funded for themselves, it undermines that. So those are some of the things I was thinking about. And as the regional center system, Dr. Hinshaw pointed out how our mental health system for community-based services is so underdeveloped. People were institutionalized, and when we closed the institutions, we really didn't develop a very robust system. And we did a better job for developmental disabilities, and by making it an entitlement. But those are the things that I was thinking about, is that we need to be careful that some of our progressive ideas can undermine some of our values, and we need to think about the unintended consequences, and whether we want to go the entitlement route and continue to support the entitlement route, and how do we improve that entitlement versus need-based services, and there are advantages to both.
Yeah, Dr. Lee, would you like to comment on a policy perspective on that? From a policy perspective.
So could I come in for a minute and make a parallel here between adult and youth services? I couldn't hear what you said because I'm on a bad laptop. I've had to move around. So were you asking for more comments, or did you have another question?
No, I would like you to respond to what you just heard.
So if you're between 3 and 21 in the US, and you have a physical or mental or developmental disability, under IDEA, the Individuals with Disabilities Education Act, you're entitled to a free and appropriate public education, least restrictive alternative. Or under Section 504 of the Civil Rights Act, you're allowed to basically sue gently a school district to provide equal access.
For the closing. Oh, weird. That's echo.
So under IDEA, parents can ask for an IEP, an individualized education program, get an assessment, et cetera, at the school. But wealthy parents can afford to get a private neuropsychologist or psychiatrist or neuropsychologist, whoever, to do an assessment that's probably bigger and better than the school would do, that gives them more ammunition to get the accommodations put in place. Under 504, it's a much more basic assessment of what the disability is and what's needed not to violate the civil rights of the individual. But it's not an accommodation for special education. It's just making things equal. Usually you don't get as many services under 504 as you do under IDEA, but again, IDEA is a classic example of a federal underfunded mandate. It's the law, free and appropriate education in a public setting. But what do you have to do to get that? You have to get an evaluation that proves you have that disability to get the accommodation. And if you do, what percentage of that accommodation is paid for by the federal government that mandates it? 20%. It was supposed to be 40% when the law was first passed in 75 and reauthorized in 1990, but it's 20%. The states kick in a little bit more, leaving it to the LEAs, the local education associations, to make up the difference. Because of the way we fund public schools in the United States, basically through property taxes, richer districts can provide more, poorer districts can't provide as much. So we get family after family fighting the schools and basically essentially fighting one another to get accommodations. And the final catch of this is many of the accommodations for kids with learning and developmental disorders, extra time on tests, et cetera, have been shown to maybe relieve stress, but not actually build skills. What we really need for kids in this is not just accommodations, but the kinds of services to build their skills to get the most out of education. So I don't want to go too far afield into the child and adolescent arena, but there seems to me, from what I'm learning from today's great presentations, is there are parallel issues of lack of access, lack of equitable services and accommodations, and we have a long way to go.
This is Andres. Let me just say from a federal policy standpoint, the National Council on Disability is part of our health equity framework. We're calling upon Congress to, together with the disability community, to define an essential list of services that that private health insurers have to provide to for people with disabilities, right? Because if we're only looking for the federal government to fund these programs, it's not going to be sustainable, right? And so when you look at the investment, the greater investment in home and community-based services, those aren't being provided by, and they're not mandated to be covered services that are provided by private health plans. And so that's something that we have to change as well. So if we're going to achieve anything with respect to improving the healthcare system of people with disabilities, there has to be the federal mandate that says that the law requires it be done, but it can't only be the federal government that's going to be funding this. So we have to look at other funding obligations as well.
So I'd like to follow with a specific policy consideration. One thing that we learned from Alice Wong's session was the importance of considering intersectional identities for people with disabilities who might be multiply marginalized. And I want to give an example of any healthcare provider who's out there in practice, who's trying to make their practice function and recognizing the limitations of reimbursement from insurance companies. Many practices, because Medicaid does not pay as much for services rendered, limit the number of individuals with Medicaid who can take appointment slots, which means that people with Medicaid are often having a delay in service provision. I see this as ableist classist, and racist. The reason I'm using those terms is because people with disabilities are more likely to be covered by Medicaid. Obviously, it's a means tested program. So poverty is baked into the way the program is designed. And that classist nature of it as a program is part of the actual intention of the program. And then lastly, both people who are from minoritized identities are more likely to have disabilities and are more likely to be poor. And so by limiting access because of reimbursement, we're setting up a system of healthcare delivery that is ableist, classist, and racist. And that's not an intended consequence necessarily. It's one about financial viability of keeping the lights on, paying the rent in your clinic space. And so I have my recommendation specific to policy is better reimbursement on par so that there isn't a disincentive to serve people who are covered by Medicaid. I also just want to briefly tie in about what insurance must cover. I think that Medicaid has a great model, EPSDT, for children that we need to make sure is expanded out and fully realized. And so I think that's both within the Medicaid program itself, but also within private insurance.
And connected to that, if each of the panelists could speak about one action item each we would like people to have coming away from the conference. We talked about the ableist, racist, classist system. How can we dismantle it? Is there anything we were inspired by when we heard each other that we would recommend to our audience?
Well, I'll kick in again. It's going to take change and action and dedication at many levels of analysis. What have we learned from the Federal Civil Rights Act? What have we learned from Voting Rights Acts, et cetera, et cetera? You can legislate equality that does not necessarily change people's minds and attitudes and values, as we have realized since the groundbreaking civil rights legislation of the 60s. And look what happened in the summer that the pandemic started with George Floyd and many other murders and racism creeping up everywhere. We need to enforce equitable policies. We've had good discussion about that in the last few minutes. We need to have an enhanced set of media images that are actively humanizing rather than dehumanizing and stereotyping and stigmatizing. We have to have a health insurance program or policy or whatever it would take in this country that truly enforces parity, because parity is the law. There's loopholes big enough to drive a semi through, and it's not in practice the way it was intended when the policies were made. And as the first wonderful talk, and then I followed up in another way, narrative and storytelling. If every individual and family has a voice, it's not shameful to talk about needing services, not shameful to talk about actual human needs one has, then no one could ignore it. And that's I think what's essentially happened with breast cancer in women, that a very stigmatized attribute and illness from half to 3/4 of a century ago has now become mainstream. So to put it back into what's an actionable step, don't think that any one strategy of change is going to solve all the problems. In fact, when we think that any one level of analysis will work and it inevitably fails, we go in that social history of a sine wave of backsliding and losing morale. And it's going to take multiple actions. And some people are better at the individual and some at the collective and some at the policy and some at the media level. So I'll be quiet for now, but that's my point.
You know, we, in my estimation, we need more of you guys, right? We need more people with disabilities in the medical profession. And then we need to celebrate the fact that you exist, right? So that students, prospective students, kids can say, one day I can aspire to be a physician as well, right? I can aspire to be in science. I can aspire to be a researcher. And so, you know, that's something that struck me as I'm listening to the various participants in the breakout rooms, the number of people in chairs that are either physicians or are in medical school right now. This is more than I've seen in 26 years since I've been injured. And this afternoon, it's just terribly exciting, right? But that needs to be celebrated and needs to be promoted.
Right? I mean, the people who are here today in the audience are part of the team, whether they're about to become a doctor in the process or already in the field. So, Amy, who's Professor Kripke, would you like to chime in with the action item?
Well, since this is a powerful group of people, I'm going to toss this out here that eligibility for services and supports, long-term services and supports, should be based solely on function, and that we should get rid of medical necessity as opposed to services and supports to maximize your function and your potential. Get rid of IQ or autism or other diagnostic labels as being a criteria for eligibility for services and supports. And that we should move because IQ tests are deeply flawed for people who don't use speech to communicate, who have motor control issues, and they have a dark and racist history. So we shouldn't be requiring people to have any specific diagnostic label in order to get services and supports, and focus on function. And word of caution about, yes, it would be nice if private health plans and other health plans paid for long-term services and supports, but again, that's pushing things out of the disability systems and into healthcare systems, which have a different philosophy, and we need to be careful of that, because you're getting into doctors having more control and undermining our movement to not out of the medical model. It's putting things back into the medical model when you do that.
Well, we need to come up with a wish list, but we need to infer.
I'm happy to follow up with some of my takeaway recommendations for action items for members in the audience here. We heard how important it is to make sure disability is recognized as part of diversity, equity, inclusion, and justice initiatives. So speak up about that if need be. I also want to echo the importance of making sure that people with disabilities are involved in the planning and programmatic changes, and that those programmatic changes are developed with a health equity framework. It is not enough just to have someone as a token representative. They actually have to have a seat at the table, a voice at the table, and power to make change. I would encourage all of us and to do this repeatedly, which is to assess our own biases. We may have unconsciously ingrained ableism, classism, racism, colonialism. And so I really encourage us to go on a journey that is lifelong about addressing those. I want to make a clear point, and something that the healthcare field really fails to do often, and the way we finance healthcare we fail to do, is to recognize mental health as health. And so I think that whatever we can do as practitioners to align and make sure that health includes mental health and is not this separate entity is really quite important. I would encourage all of us who are practitioners to see our individuals with disabilities who are our patients as individuals and not by their diagnoses. I think Clarissa made a really important point about that, and help people with disabilities achieve their goals and engage in shared decision-making, not put upon them what your goals might be for them. And that, I think, extends to the idea that we do not impose upon others what our assessment of their quality of life is. That is not for us to decide, and that we should make sure that we are recognizing and respecting and valuing what their vision of a full and healthy life is and how to achieve it. I would also encourage us all, just as we are taught to be upstanders and address racism when we see it, that we also address ableism when we see it. And in particular, I think that's relevant, especially when we're involved in the care of people who have been multiply marginalized. Their voices have been diminished over generations, and that we can be an powerful voice and to elevate theirs and then shift the frame over to them for them to have their voice heard. So what I think that all comes down to is that we're advocating for goals around health, function, and well-being that people, our individual patients with disabilities have. And then we advocate as well, if we're an ally or an individual with disabilities, for in general, equity in service delivery, equity and opportunity, and an anti-ableist framework for everything that we do.
That's an
Amen.
excellent,
Amen.
excellent point. That
Amen.
brings me to my next thought. That in some ways, today we might be preaching to the converted. Because we're together, we're a community of scholars, practitioners, students, with and without disability. We support this. How can we enlist the rest of society of people who are not so familiar with these issues? How can we engage them?
This is Andres, forcibly, right? We have to get out there and just spread the word. And again, break out of our silos and reach across the aisle to engage in these important conversations. You know, I reflect, given where we are today in our politics, that if the ADA came up for the vote today, would it pass? The chances are no, absolutely not, right? But yet, once individuals see disability as part of their life or the immediate family member's life, their opinion and their values tend to change. So we have to make this personal, but we have to get out and again, not just speak to those of like mind.
I mean, maybe that should be part of our take-home message, that we need to go out there and speak to people who may not be aware of these issues, instead of only speaking within our own communities.
Yeah.
And that might be hard work, that might be a fight, but it's an important fight in order to advance what we need to do. A common theme today for me with the issue of stigma. So I wanted to ask Dr. Hinshaw about stigma and how we spoke so powerfully about your own father's experience. How do you think we can better address the stigma of mental illness going forward? What work has been done and what needs to be done?
Well, thank you, and I'll pick up the call for a moment here anyway. Clearly, it's going to take policy level, media level, treatment access level, social contact and humanization, you know, the sort of 5 levels I outlined in my last slide. But I want to get a little more personal about what it's going to take. When my dad was aging and then finally developed his Parkinson-like illness, which I'm convinced is at least in part iatrogenic, caused by the wrong treatments for the wrong diagnosis. And Dad had disclosed to me more than my mom or sister. He grew up with all boys. He'd been abused by his stepmother. And after Dad's death, I started to get more involved in stigma academically and advocacy-wise and doing interventions with young people, et cetera, and started to write and talk about it. And I had a conversation with my mother, who by then was in her 80s, born and bred in Columbus, Ohio. And she said, Stephen, it was always Stephen when there was Steve was when things were going well. Stephen when there was maybe a little bit of an issue. You have an axe to grind with the psychiatry profession. Your dad was mistreated. But I really don't want to read about our family's story in the New York Times or in a book. These are shameful events. I had to really hide them from colleagues and friends my whole life. And so it was a big crisis for me as I was starting to publish my first monograph about Dad and proceed with all the work I've been doing since then. And my wife said, Steve, I know your mother well by now. Don't cave in and say you'll never do this. Don't get into a battle. When she sees how much this means to you and her whole family, she'll understand. And I said, oh, you didn't grow up in the Midwest and you didn't grow up with all that shame and silence and stigma. But Kelly, my dear wife, was right. And as I proceeded and persisted, Mom would occasionally call me and say, well, why hasn't this been reviewed in Time Magazine? We need to, and then at one point she said, our family will be silent no longer. And I will tell everyone, if my, at that point, 85-year-old mother from Columbus, Ohio can overcome stigma, anybody can. But it takes openness and it takes courage and it takes one foot in front of the other and coming out of the closet at all the levels we've been talking about.
Mhm.
That's powerful. We will be silent no more. Let's bring me to Dr. Futsal and Dr. Kripke. And I wanted to ask you both how you think stigma impacts your work, specifically shifting from child services to adult services. Maybe we'll begin with Dr. Futsal.
Certainly. I want to start with a slightly different transition. In childhood, when children are about 4 and 5 years old, if they use a wheelchair, they're like the coolest kid, right? Wheelchairs are so cool. Other kids want to play with the wheelchair. And relatively shortly thereafter, by first grade or second grade, the other kids have realized there's something not good there. And they're engaging in the discrimination, potentially even the bullying of children with disabilities. This happens because we're socializing children with ableist beliefs. And sometimes we don't even know we're doing it. You may have seen somebody in the grocery store, for example, who uses a scooter or a wheelchair, and a small child is staring at them. That child is staring out of curiosity. But oftentimes what happens is their parent says to them, oh, no, it's not nice to stare. Come with me. No, don't look. And what that's enforcing in for that child is there's something bad there, not something interesting, but something bad. And there, if you would ask that mother, was she attempting to teach her child that disability is bad? She would say, of course not. Well, so children are getting reinforced. Children with disabilities are getting told by society, and they're internalizing this ableism and their the stigma associated with it. And so by the time they're doing their identity formation during adolescence, by the way, adolescence is hard for all kids, but it can be especially challenging for identity formation for kids with disabilities because of this internalized ableism. And I see that as a major barrier to successful transition is the belief that they're not worthy of whatever their hopes, goals, and dreams are. And I think it's incumbent on all of us to shift society so that we can assure that children and youth with disabilities know that they are valuable and that their dreams and hopes and goals are worthy of pursuing. So that's how I see the kind of trajectory of stigma into the space of transition from pediatric to adult healthcare.
That's a powerful example, and of course, a child who feels the stigma might be less able to then advocate for themselves in a medical setting, and they might have providers who themselves have their own biases. Dr. Kripke, would you like to comment?
Yes, so I think you're right that people learn these attitudes young, and that and your point, Dr. Hinshaw, about storytelling is so important, which is why it's so important to have healthcare providers and other role, or as in our group, they said not role models, but possibility models for people to see what people with disabilities are doing and are capable of doing. And in that light, I just want to point out who's not at the table. Even within the disability community, there are more and less privileged disabilities. I'm on the board of Communication First, which is the first national organization advocating for the rights of people for whom speech is not reliable communication. And I hope that in future conferences we'll have more people who don't use speech to communicate presenting and sharing their stories, because I think those stories are just beginning to be heard within the disability community, within the autistic community, within the community of people with physical disabilities. And it's certainly a healthcare issue, both in terms of, do we give people access to communication when they're young? If we don't, then the chances that we're going to be able to get people effective, robust AAC when they're older diminishes. So it's really important that people not just be introduced to AAC when they're augmentative and alternative communication methods when they're in school, but that those are generalized across not just in school, but outside of school, and that their families are using them so that they carry over from youth to adulthood, so that we in the disability community are also comfortable with people with speech disabilities, and including their stories and including them at the table, and that will help to reduce stigma for everybody.
Absolutely. That's an excellent point out, Dr. Guerrero, from a policy perspective. How has stigma prevented or maybe affected the work that you do on a national level?
Well, I mean, look, stigma has everything to do with it. It's stigma is how we're received, and Capitol Hill, when we roll into a particular legislator's office to talk to them and staff about issues affecting disability. If they don't have constituents or they don't have family members that have disabilities, then are they going to be as receptive as they otherwise will, right? We need to see stigma addressed also on TV and in movies, right? Again, to see people with disabilities, not as victims, not as casualties, not as somebody, who should be pitied and felt sorry for or subject to charity, but as the protagonist in movies and in shows, etc. Why can't there be a good doctor in a wheelchair? We had Dr. House who used a cane, but that wasn't enough, right? So we need to see more people with disabilities on the screen as well. But look, yeah, I mean, what we're trying to fight at the national level in our policymaking is addressing that stigma in many different aspects.
This is perfect timing. Right now, we have an anonymous comment saying that Dr. Mary Austin, who both treats people with spinal bifida and herself has spinal bifida, did not disclose that because she doesn't want her patient to assume they will have an outcome as good as hers. Can you comment on the paradox of expectation and representation in healthcare?
You need to have high expectations. I don't know what that is about.
I think this is a really interesting topic.
I'm sorry, this is Lena here. I'm sorry to interrupt. Just want to make a quick pause to make sure what I said came across clearly. So I'm going to sign it and the interpreter is going to voice it. So are you saying that Mary Austin, who is both treated and herself has spina bifida and is not willing to disclose that with her patients, in part because she doesn't want her patients to assume that they'll have the outcome the same as she has? Can you comment on the paradox of representation and expectation setting in the healthcare setting? Thank you. I just want to make sure it was clear. Please carry on.
I think that paradox of expectation versus representation is one that each provider is going to maybe come to their own conclusion about that might be different than mine. As a person with genetic childhood onset disabilities, I think my patients appreciate and their parents appreciate seeing me in the role that I'm in. Perhaps sometimes they think, oh, well, Dr. Houchow can be a doctor, maybe you can be a doctor. I'm a believer in the promotion of hope as well as reasonable expectations. I see it as part of my job to provide patients and families with a sense of what a likely outcome might be. I make no promises or guarantees, but I talk realistically about what functional outcomes we may expect with whatever treatment we might be pursuing. And we all have hopes and dreams, and not every one of those will come true. But aspiring means that we have action to take and growth to do. And I think being inspired to achieve something, even when it might not be achievable, like, for example, I want to be a doctor with disabilities on Sesame Street for kids with disabilities on Sesame Street. I might never achieve that dream, but it's still a reasonable one,
so cool.
right? And it still buoys me for action. So the idea that you wouldn't want to give someone a false expectation, I think is somewhat flawed, because as a healthcare professional, part of my job is to engage in goal setting and realistic expectations and a path to try to achieve those goals.
I'm going to cut in really quickly. I'm reminded of a now fairly famous study done by NAMI, sponsored by NAMI, the National Alliance on Mental Illness, a number of years ago, with questionnaires sent to 2,000 adults across the US with bipolar disorder, severe depression, or schizophrenia, and then a follow-up qualitative interview with about 100 of them. And one of the sets of questions asked, from whom do you receive the most stigma in your life? Family members, people that you work with, et cetera, et cetera. And for just about every participant, the number 1 or 2 answer was my providers.
Sure.
Especially my shrink, my provider, my doc never thinks I'll finish school, will never hold down a job, below expectations. Now, some were more egregious. Some of you may know the acronym GOMER, G-O-M-E-R, get out of my emergency room, which is a stereotype but true epithet used by some emergency room docs. Well, I'll take people, victims of a gunshot wound or car accident, but if you abuse drugs or hearing voices, you don't have a real illness, get out of my emergency room, let's save it for the real patients. So I hope that has changed the way we're starting to see some national changes in stigma, at least toward depression. But people, the consumers, the people with lived experience are telling us that probably because of the way we as professionals were trained, it's us versus them, healthy versus sick, we know, you don't, that consciously or probably more unconsciously, we're putting on values that really limit the potentials of so many.
That's a great point.
Can I briefly note, though, that disclosure of your disability is your choice alone. When I'm in a room, people know that I'm disabled. That's something I can do to hide that. But for many people, it might not be abundantly obvious. And forced disclosure, I don't think benefits anyone. And so if a physician has a disability that they choose not to disclose, that's a disability that they choose not to disclose.
I don't walk around the UC or UCSF campus with a sandwich board on that says, Dad had severe misdiagnosed bipolar and I've had serious depressions. It's about timing, rehearsal, and support. The right time, the right place, maybe not during a job interview, maybe you won't get that job, but once you've got the job, ADA should and could protect you. And so it's not mandatory. Pat Corrigan, our colleague at Illinois Tech, an international stigma expert, has developed a program that's now called HOP, Honest, Open, and Proud. And it's a program to do group support for high schoolers or college age students in the workforce or in school to discover when to start to tell other people about their autism spectrum or their bipolar disorder, or what have you. To really, it's out of empowerment, not what we can't have is when I grow up, you can never talk about it. But forcing disclosure is not the answer either.
Yeah, I'm happy we're talking about this. Many people in our audience are in medical school and they're struggling with the same issue, whether or not to say something or not.
Well, and they're also struggling with trying to get accommodations, right?
Yep.
Once they do disclose, so it's a problem. The issue of disclosure is a personal one. It's a very sensitive one. The law is there to protect you, but once you disclose any negative thing that may happen, there's always the perception, is it happening to me because, right? And how do you deal with it? I think how that's dealt with at each institution is leadership. And it goes back to having a presence of people with apparent disabilities so that people understand that at the leadership level, they embrace disability, or at least they pretend that they're welcoming. It makes it easier to disclose. But again, the more of us that are out there with disabilities, whether any type of disability that have the presence to disclose, the better it's going to be for the rest. There's strength in numbers.
Absolutely, strength in numbers. So I was thinking and reflecting on the fact that it's been 30 years since the EDA. I'm really a product of the EDA. I would not be here today where I am as that associate professor without the EDA. I wanted to hear from everyone here, where are we now and what still needs to be done? Your first credit when the EDA was signed in 1990, the shameful wall of exclusion and stigma is coming down.
Well, look, there's an incredible promise to people with disabilities when the ADA was enacted in 1990, right? Full inclusion, equality of opportunity into all segments of society. The promise has not been kept in many areas.
Right.
And sadly, the main area where it hasn't been kept is in healthcare. So when you look at the ADA and what it doesn't include very specific language to healthcare providers. And as a result, in my experience as a disability rights attorney, I see many healthcare providers, obviously present company excluded, that hide behind the lack of specificity in those regulations and in the law that speaks to them directly. And they view it as Dr. Hinshaw, I believe, mentioned earlier, as an unfunded mandate. And therefore, if there is no financial remuneration that comes with having to comply with the law, then why comply, right? They're sitting back and doing cost benefit analysis because there's really been no severe repercussions for not providing accessible care. And I would love for the Department of Justice or the Health and Human Services Office of Civil Rights to take away a healthcare system's ability to participate in federal financial programs and receive that federal financial reimbursement for having discriminated against people with disabilities. That would send a signal, but that probably will never happen, right? So the ADA it's an incredible piece of civil legislation protecting the rights of people with disabilities. It's been the model legislation for legislation throughout the world, comparable legislation. But we need to do more. It doesn't. It's absolutely correct, Dr. Hinshaw. You said earlier that legislation and regulations do not change how people view and how they act. Dr. Martin Luther King is one of his famous quotes is legislation cannot change hearts, but it can tame hearts, right? And that's the purpose of it, is to restrain the wrongdoer, the person with malintent from causing injury and then providing protection in the event injury does occur.
Lisa Izoni recently published a paper looking at physical access in exam rooms and healthcare facilities. And we do poorly with that. And I think anyone with disabilities who may need assistance for transfers, for example, would recognize that, or anyone who needs sign language interpretation or a screen reader in the healthcare space may recognize how poorly we do in healthcare. But one of the things that I think is important to consider is that healthcare professionals themselves are part of a bigger organization, and it's often organizational leaders that can drive access change. So it's not a physician practicing at a children's hospital like I do, but it's the administrators that can make those changes happen. And I think one thing we need to do, because I really hear you when you said about well, we're talking to like-minded folks, how do we expand it out, is by really getting the buy-in from leadership to make those changes feasible. And so that, because of course I want my exam room to be entirely accessible. And let me tell you, it took me 5 years to get a doorway that was accessible by a switch instead of a pull open the door, because it wasn't my choice to make that happen. And so I really think this is one of those we need, for those of us in the healthcare space, to mentor up to our bosses and administrators for them to see how important it is. And we're far away from realizing the promise of the ADA, just like we're far away from realizing the promise of Olmstead for people with disabilities to be in the community.
Mm-hmm.
We have a long way to go. I just saw that Peter Pudius, who's running the conference, said, is anyone up for a good old-fashioned protest?
There you go. Yeah.
And with that, we just have a few minutes left. So I thought, if it's not too ambitious, if we could come up with a call to action manifesto. If people
Judy, Human
come
gonna
up
lead
with
it?
just a few word sentence, go ahead. Dr. Hutra?
I was just going to say, is Judy Human going to lead it? Because she seems to be the queen of the protest movement.
There you go.
Bring her on.
She would be perfect.
If there was going to be a slogan, I would pull back what one of the questioners talked about, that in healthcare, we don't need reasonable accommodations, we need access, and access isn't always reasonable. We're going to have to change fundamentally how we deliver care.
I would just echo what Dr. Hutrell just mentioned, and that is, we need dynamic subordinacy with individual physicians and mentor up and be champions and encourage them and support them and give them the resources they need to be champions for accessible healthcare within their healthcare system, within their hospital, so that they can convince administrators that don't get it how to get it, right?
So one thing that I think happens in these discussions is we often feel like we can't actually exact the change that needs to be exacted. And people often think about revolution versus incremental change. So, and I think the point about perception and stigma and discrimination in societal views, right? There is no, flip the light switch. Even with big societal changes, such as during the civil rights movement, there still is a lot of lingering. Sometimes it even feels like we're slipping backwards in some spaces. But I would encourage us all to feel really empowered to make change. So whether that's advocating for one single individual, or really making change in an organization, or promoting legislative changes. I mean, we all are accesses of power. And I think we should try to own that power as much as we can, and recognize that even when it is one by one individual, that's meaningful. And the summation of that is greater than just the sum of its parts. And so when I think about a disability justice and disability rights perspective towards healthcare, I see it as both that incremental, sometimes one by one, but also transformational. And so I would just encourage everyone to feel the power that they have within them to make change.
Adding on to this both and mentality we're getting into, it's going to take in mental health and neurodevelopmental disorders, both having a wider band of appreciation for human diversity and ensuring access to care for treatments that are needed. It's not either or, it's both.
Absolutely. Any final thoughts before we wrap up?
It's been an honor to be in this Zoom room with everyone.
Likewise. Thank you.
Yeah,
Totally
what an
agree.
amazing day.
Thanks all hosts and organizers for a pretty darn awesome day.
Right, and I feel like everyone today watching, That's the panelists, the conference organizer, we're all part of a movement. Yes, we've accomplished a lot, but we still have a long way to go. And I think we all hope to continue this conversation. So thank you all to the panelists for your time. And now I would like to turn it over to back to Dr. Peter Prudios, Clinical Associate Professor of Radiology, who leads Stanford Medicine Alliance for Disability, Inclusion, and Equity for closing remarks. Thank you.
It would be so good for my self-esteem if people just kept their browsers open. You don't even have to stay around and listen to my remarks, but at the end of the day, I always watch the graph drift like this. Like the second my closing remarks start, the viewership drops to 0. So just, keep your browser windows open. Yes, thank you so much. That was an amazing and inspiring day. I really have no words. I'm going to share a slide deck right now with some closing remarks. Lizzie Zudok is going to join us as well, my co-planner. Let me just pull up the, share the screen. All right, so Lizzie's gonna start.
Okay, so just to start off, these are our closing remarks. What we wanted to start off by doing was sharing a word cloud from the Slido that showed what some of the most popular words across the conference were. So one of the words that really jumped out to me is mental. Multiple sessions across the day have talked about the effects of internalized mental health stigma and how overcoming both overt and internalized stigma can immeasurably improve the way that we see ourselves and how we experience our life. Another word is lived. We have seen across the conference that the power of our lived experiences for advocating for ourselves and other people with disabilities and chronic illnesses on a personal, institutional, and national level makes a huge difference. People listen to our stories. Data science is very, very important, but stories is what really catches people. The final word that really spoke to me was training. And this is obviously something that's very close and near and dear to my heart. I think as a student, we are in an exceptionally powerless time of our lives. And, we do our best to advocate for ourselves and our peers and others. But I really think that the power of storytelling, advocacy, and allyship from people in those positions of powers makes a huge difference in the environment that we train. Next slide, please. Next, I want to bring attention to some of the highly upvoted comments on Slido that really resonated with the conference themes. This first slide deals with the terms accommodation versus accessibility. First, Dolly says, I think we need to stop talking in terms of accommodating and start talking about accessibility. I see these as two different things. One frames it as a special burden, the other doesn't. This comment really reminded me of when Alice was talking about how we see our disability and we sometimes internalize it as a lack of strength. The word accommodation has really kind of been like a trigger for that for me. And it internalizes to me that I see myself as a burden. But when people talk about accessibility, I see that accessibility is an improvement that really helps me, but also helps all peoples in the disability community, and then in the greater community at large. And during COVID, the way that we worked in medical education, or the way we did medical education in the pre-clerkship curriculum, really improved for every single medical student, not just those with disabilities. An anonymous person then replied by saying, this is so true. It's especially ironic since I often feel like I accommodate my school's disability office much more than they accommodate me. They get to work on their own timeline, often significantly delaying accommodation. they get to choose what's reasonable based on their convenience. And this is such a powerful statement that really resonates, I think, across students with disabilities just altogether. My peers and I have struggled with this exact same experience across many institutions. And sometimes when they are trying to provide their legally required accommodation, it takes forever. And then they force me to disclose information that would otherwise be like private health information between me and my doctor. Yeah, so let's move on to the second slide.
Can I just say one thing about access real quick? There's this organization in LA called 1 in 4, and they're trying to improve representation of people with disabilities in show business. So Dr. Houtro, I know that you have ambitions of being a star. I can put you in touch with a woman who specializes in being an agent for disabled people. But you'll have to get in line because I've already started taking acting lessons in preparation for my starring role. So that holds for you too, Andres. I know that you have acting aspirations. But anyways, so their slogan, that's not why I brought this up. Their slogan is add the A. So, and the A stands for access. So we should stop talking about DEI. We should be talking about DEIA, diversity, equity, inclusion, and access. And if we can consistently add that A onto the end of DEI, I think that might help, solidify our place in these efforts. Thank you.
Okay, so the second slide deals with allyship. So an anonymous person stated, part of advocating for any marginalized group is relinquishing unfair advantages given to you from your own privilege and status. Allies need to learn this. Performative inclusivity that does not relinquish power is not enough. Sabella replies, performative inclusivity is insidious and becoming more commonplace. We need to continue to challenge this. These are such good points. If people, businesses, institutions, and other leaders are going to publicly state that they are allies, it's important to walk the walk and include and listen to people in the disability community and put them in positions of power. Thank you. I'm going to pass the mic to Dr. Poulos.
Thanks, Lizzie. So I just want to reiterate the 10 principles of disability justice to burn this into our hearts. Intersectionality, leadership of those most impacted, anti-capitalism, cross-movement organizing, recognizing wholeness, sustainability, cross-disability solidarity, interdependence, collective access, and collective liberation. And this idea of interdependence really resonated with me today. It's one of the things that just keeps me going when I'm having a bad day or feeling sorry for myself, that I depend on caregivers and others to help me out and do my ADLs. I think about the ideas of interdependence. And it was actually, I'm not religious, but my priest introduced me to this concept for the first time. And I think that it really is something to live by. As Alice said, the state isn't going to save us. The state has to do its part, but we can collectively help each other. And then this idea of cross-disability solidarity, not breaking out of our silos, making sure that we're including everybody. And then also the cross-movement organizing, finding allies within the diversity community. There were some comments in the chat about being excluded from diversity initiatives. And what people can do to overcome that. And I think that finding allies is the most important thing in trying to get recognized. And if they don't want to recognize you, how about a good old-fashioned protest? That was my some of the things that we were talking about in that wrap-up session really made me want to grab a picket sign and And I think that we might have to do that sooner rather than later. Andres, I really like this quote from Martin Luther King that you put up. And when I was going to put only that quote in the slide because, but then when I Googled it, there was like this top 10 quotes from Martin Luther King having to do with disability. And I thought that these other ones were really pertinent to our conference themes. Like injustice anywhere is a threat to justice everywhere, speaking to cross movement organizing and cross disability organizing and showing up for each other. It's not possible to be in favor of justice for some and not be in favor of justice for all people. That speaks to the same thing. Everybody can be great because anybody can serve. You don't have to have a college degree to serve. You don't have to make your subject and verb agree to serve. You only need a heart full of grace, a soul generated by love. And I chose this quote out of there because one of the people today was a patient in my breakout room, and he said that he felt a little out of place talking without a medical degree in this crowd. But we're not asking. We certainly can't ask our patients to serve because they're already paying such a huge tax already in our broken medical system. But for those who can and want to, banding together and allying with physicians can be a very powerful way of making change. And I would urge for patient groups and physician groups and provider groups to bond together and work together. That will very much synergize our efforts. And then this last one, true compassion is more than flinging a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring. And this one really resonated to our ideas of accommodations and how sometimes we feel like a beggar when we're going to the disability service office or our boss and asking, please, will you give me an accommodation? I'm sick of feeling this way. I know a lot, and I get accommodated pretty well. So I know that a lot of other people are sick of feeling this way also. This is another takeaway point that was highly upvoted. By the way, Sibel Sack won the most upvoted award for the day on Slido. So congratulations, Sibel. The idea that all doctors and other HCPs need to be able-bodied and flawless is so bizarre to me. In my experience, it is so much harder to counsel people about things that come naturally to you: walking, losing weight, obtaining transportation, etc. And then another anonymous response says, it feels very eugenicist that only the healthiest among our society should have access to the knowledge and training necessary to manage disease and disability. And, I think of would you ever hire a person to coach a basketball team if they'd never played basketball? Why are we admitting able-bodied people to medical school? I think it should be a prerequisite to have a chronic illness or a disability in order to take care of patients. And from backstage, the top themes of the day: entrenched ableism in healthcare curriculum, the difficulty of disclosure of mental health disabilities, and internalized ableism and stigma, which were talked about throughout the day. This is within our power to change these things. It's going to take time, but part of the goal for bringing this, for holding this conference and bringing people together is to break down our silos so that we can get to know each other and work together to move things forward. And here are the thank yous. So our conference planners, especially Katie, for pulling this all together miraculously with an Excel spreadsheet that has 20 sub-tabs on it. Thank God for you. Amy Thomas for our web and media, Denise for the administrative support, and Sheila for arranging our access. The planning committee, Hannah, Dakeen, Amanda, Megan, Heidi, Jody, Shayla, Lori, Jen, Fatima, Megan, Majiza, Doug, and Lewis. And a huge shout out to Lewis and the team. You did it, man. You did it. The board of directors of SMATI and my co-conference organizers, Dr. Ken Sutha, he got demoted from MD PhD to only MD, my co-chair, and then Lizzie Zudok, the co-president of MSDCI. Thanks to both of you for all of your hard work pulling this together. We couldn't have done it if not together as a team. And last but not least, our sponsors. We had so many generous donations that will allow us to not only hold this conference, but to drive our mission forward. That's MSDCI, radiology, psychiatry, IDHE, internal medicine, obstetrics and gynecology, chemical and systems bio, neurosurgery, the Office of Faculty Development and Diversity, anesthesia, perioperative and pain medicine, and radiation oncology, and closed captioning provided by the Stanford Diversity and Access Office.